My name's David Sanders, and I want to welcome you and thank you for coming to what appears to be a focus group in my mind. I'm going to talk to you a little bit about why focus on faeces. This day and age we have to declare conflicts of interest, and as you can see I've got many of them. So I thought I'd start with this picture, which is something that we all have in common, and we do many things here. Some of us try and avoid people by going in there, have a read, contemplate life. But from a gastroenterologist's point of view, there may be something in terms of faeces which actually offers us insights into GI disease. But when I was a medical student, going back about 25 years, it was mandatory to stool gaze, and this is now no longer the practice, apart from Gina McKee. So why look at faeces? Well, you can see here there are a number of markers which may allow us to identify GI disease, and I'm going to particularly talk about my areas of interest, which is pancreatic elastase and faecal lactoferrin. If you have any involvement in pancreatology, one of the very difficult things is that there really isn't a great test, or I might say to you there was not previously a great test. Imaging doesn't really pick up things that are subtle, tends to pick up chronic disease. The ERCPs and the diagnostic interventions are very aggressive and have complications attached. EUS is ongoing, but it's time-consuming and expensive. And the non-invasive tests, patients simply don't like to collect them. And I'm sure, I don't need to tell you this, but you all remember things like fecal fat collections, and the patients just don't bring them back. So fecal pancreatic elastase, I think, is useful. And the message here in this slide is that it's not, as again I'm sure you all know, it's not biodegradable, which means we can measure it in the stool. It's got a very good intra and inter-assay variation. That's a picture of fecal elastase. I have no idea what that means, but I like the look of it. Again, I won't be preaching to you about ELISAs, but this is how it works, and it's a very standard kit. So how do we take this forward into clinical practice? Well, if you look at what others have done with fecal elastase, broadly looking at chronic pancreatitis, then it clearly has great value in severe insufficiency and some benefit in moderate, and then tails off a little bit with mild insufficiency. But I still feel, when compared to other tests, to my mind, this is becoming what I would view as a gold standard for real clinical practice. Now, the Sheffield group of researchers in GI have got an interest in celiac disease, and this is work that we published in BMJ a year or two ago. And bearing this in mind, we have quite a large cohort of people with persisting symptoms. The relationship of pancreatic disease and celiac disease is very well described. It dates back some 35 years. Having said that, on many occasions, it's something that we overlook, and perhaps that's because we haven't really used the right tests. So, having thought about this, and I really by chance attended a talk by someone else about fecal elastase, it came to my mind that maybe individuals with celiac disease could have underlying pancreatic exocrine insufficiency as a reason for their persisting symptoms. Usually what happens is we tend to think it must be compliance, but this was a thought that I had in my head. The picture on the left, if you have ever been to this, is the Royal Hallamshire Hospital where I work, and like all good teaching centres, it has many psychopaths, myself included. So I'll tell you a little bit about the work that we did in this study. What we did was we took a very broad brush approach. We said, right, let's test everyone. Let's see how common this problem really is. So we used 4 groups: newly diagnosed patients with celiac disease who initially were not on a gluten-free diet, people who were asymptomatic, people with ongoing symptoms, which is perhaps the group that I want to focus on, and a control group. Overall, we recruited about 260 patients. And if I remind you again that Group C are those with the persisting symptoms, then if you look at the cutoff level just here, and if we use 100 there, you can see it's really very obvious that this is the group with the largest number of patients with a low fecal elastase, and that actually progresses in the lower than 200 group as well. So what we then did was we intervened in that particular cohort. We gave them Creon. We'd already looked at the number of times they were opening their bowels. We'd assessed their compliance by taking duodenal biopsy and looking at their celiac antibodies. And the improvement was quite dramatic. For me, this is a great clinical triumph because you have these patients, you want to make them better, and here is a fairly simple intervention which, in many ways, I almost wished I'd thought of sooner. So to summarize that data, in the group who had persisting symptoms, a third of them actually had exocrine pancreatic insufficiency. We started them on Creon, we titrated their doses to higher levels, and by doing this, we were able to achieve clinical improvement in terms of reducing stool frequency in up to 90% of cases. So I feel that's fairly unique data, and I think it has led to a change in clinical practice broadly, and it's now something that we are thinking about in terms of guidelines for celiac disease management. Moving on to another very common area, I'm sure you're all very familiar with IBS, irritable bowel syndrome, which again I would hasten to add is not a disease. This is something that occupies gastroenterologists a lot in terms of their outpatient practice, up to 30 to 50% of referrals. So I had a very simple view of this. My feeling was if pancreatic exocrine insufficiency is so common and you have people presenting with abdominal pain and diarrhea who may be labelled as IBS-type symptoms, why could they not also be a group who have unrecognised pancreatic insufficiency? So what our group did was we looked at consecutive patients presenting to the Hallamshire. We used the Rome 2 criteria, which are standard diagnostic criteria for IBS. It's really a symptom questionnaire. We investigated them as we would normally for IBS, but in addition, we checked individuals' fecal elastases. And we again intervened with pancreatic supplementation and investigated patients accordingly. I think this particular table is quite striking. What it shows you is that the prevalence of exocrine pancreatic insufficiency at a level of less than 100 in the diarrhea-predominant IBS group is 6.1%. So that's a really large group that you can remove from further investigations and treat and improve their symptoms. This is it in figure format, and again, it's quite striking and shows you that by comparison to controls, there is something to this observation. So what happened with therapy? Well, we'd learnt a little bit from our initial celiac work, so we both treated the controls and we also treated the patients with reduced fecal elastase levels. And once again, we were able to show a significant reduction in stool frequency, and this benefit to these individuals has persisted over time. So this is work that we're still in the process of publishing, but I feel that it is something which may change the way we think about IBS. Moving on to another area where we've hopefully made a small contribution is fecal lactoferrin. Now, again, I'm sure you're all very familiar with the fact that lactoferrin is activated by neutrophils, comes out of the bowel during inflammation, and hence can be measured in this way. And from a clinician's perspective, where we thought maybe it might be valuable, we'll be picking up and separating IBS from inflammatory bowel disease. Here you can see the inflamed mucosa with a lot of mucosal ulceration. Is it possible that actually you can see lactoferrin in the stool before this whole picture develops? And maybe we can even use it as a means of separating out patients at the very beginning in terms of presentation. There's been a limited amount of work done in this area, as you can see from this table, and we set out to look predominantly at the IBS group. We recruited 465 patients. This is the largest study in terms of IBS that's been shown in the literature to date. At the same time, we took individuals with inflammatory bowel disease and healthy volunteers who'd filled out a GI symptom validated questionnaire. we used something called the Harvey-Bradshaw Index to try and assess the degree of severity in patients with both Crohn's disease and ulcerative colitis. And what I'd say to you is it's a relatively well-used questionnaire. It is subjective. It's not the be-all and end-all, but I think it helps in terms of trying to stratifying individuals as to whether they have active or inactive disease. Here are the actual measurements at the time. And you can see here that you've got your ulcerative colitis group, your Crohn's disease group, and irritable bowel syndrome and the healthy volunteers are at a very similar level. So if I show you actually the raw data, then what you can tell here, and I think this is quite meaningful, is if you have inflammatory bowel disease, you have significantly higher levels of lactoferrin than if you do irritable bowel syndrome or if you're a healthy volunteer. So what this really, in my mind, encapsulates is that maybe there is a role for lactoferrin in the patient who presents with unspecified gastrointestinal symptoms. Perhaps there may be a way of avoiding endoscopic investigations in this particular group. Because we had the data, we then split it up further and looked at active and inactive disease, and again, we were able to show significant differences. And again, just looking at the raw data, you can see that if you have active disease, it follows that your lactoferrin rises, and this is irrespective of whether you have ulcerative colitis or Crohn's disease by comparison to the inactive groups. We use the IBD scan, which is potentially a quicker test. And I think what is impressive here is the negative predictive value. And for me, what that tells me is, once again, if I'm in a situation where I'm trying to figure out whether a patient needs further investigations or what am I going to do, this may be a useful option and avoid invasive endoscopic tests. I've put this up really to show you that the area under the curve is 0.92, which I think is very respectable, and gives you a feeling that perhaps this test is now coming into clinical practice for this particular group. When we look at other groups who've tried to tease this out, I think this is quite an elegant study from a German group. And what they've done is, again, they've taken the same groups, ulcerative colitis, not inflamed and inflamed, Crohn's disease, not inflamed and inflamed, and IBS. But they've also looked at calprotectin, a neutrophil, fecal marker, and standard clinical parameters. And the areas that I've highlighted in print show you, I think, what is supportive data, which is that if you have inflammatory bowel disease and it is active, your lactoferrin will be much higher than if you don't have active inflammation or if you have irritable bowel syndrome. So how would I conclude this? What I would say is I think fecal elastase is established in chronic pancreatitis, but I think it's now finding its way in, and I would certainly consider using it in any adult celiac patient with persisting symptoms. I think in due course it may become a first-line simple test for individuals with irritable bowel syndrome. There is still much to do with fecal elastase. There's work to be done, I think, in inflammatory bowel disease, diabetes and alcohol-related liver disease, to try and establish maybe whether these individuals have exocrine insufficiency. There's already some work to suggest that they probably do. With fecal lactoferrin, I think it's cheap, it's easy to use for the clinician. I think it really does differentiate between IBD and irritable bowel syndrome. It may have a progressive role in discriminating between patients who have active inflammatory bowel disease and ongoing inflammation and those who do not. And I think, for me, the next big step for this is to see how it would perform in primary care. Could this be used as a discriminatory test at that point of care to determine whether someone's actually referred at all? Finally, I'd like to say thank you to John Leeds, Andrew Hopper and Rena Sidhu, who have all three been research fellows with me in the last 6 or 7 years. And to be entirely honest, I'm nothing more than a mouthpiece. They did all the hard work, and it's really easy to talk when you don't actually do any work yourself. Thank you very much. Any questions? Yeah, so I'm just repeating it for the sake of the recording. The question is, has any work been done in diabetes? And the answer is yes. What's been done is really looking in a cross-sectional manner at people, and it's been shown that the prevalence of exocrine insufficiency using fecal elastase is quite high. One particular study tried to tease out the differences in terms of if you intervened with a pancreatic supplement, was there any benefit? And it didn't really show a particularly good result. What I would say of that study, having looked at it fairly carefully, is I think they went for the wrong patients. They took a cross-sectional approach and then intervened, whilst I would go for the people who have persisting symptoms and then see what happens. And I think it's a study that's worth considering, actually. Okay, thank you very much.